First of all, I'd like to thank the symposium for this opportunity. Germany is quite a nice country. I mean, back in Denmark, I may be a very old man before I earn my doctorate. And here in Germany, I'm already a doctor. I may even become a doctor sometimes. So that's sort of awesome, I think. Anyway, I'm going to give a talk about suPAR in the emergency room. I will not present very much data, but instead give you my opinion on the matter. This is the entrance of the emergency room at our hospital. I didn't bring a big picture of our hospital. Instead, here we have an apartment building on the other side of the street. I imagine it's quite a cheap apartment because their view of our hospital is this south wall that we use to keep patients in. And for comparison, another wall that you might know, which is slightly nicer, I think. Anyway, on a more serious note, actually in the emergency department, the real problem is actually that you have anything ranging from dead patients, very ill patients, healthy patients, and you need to know what to do with them. At med school, this is sort of easy because we know there are different diseases, and based on a proper diagnosis, you would also know what is the treatment and what is the prognosis. So this is the quite easy part. I've brought two cases. You see an IV drug user. Oh, I disclosed it. IV drug user, low blood pressure, high pulse. There is a systolic murmur over the heart. Lactate is high. Can anyone tell me the diagnosis? Okay, I will disclose it for you. There is no trick in it. This is a young man who presented with jaundice after dieting for a week. He has a bilirubin of 45, otherwise everything is normal, but his general practitioner worried that he might be suffering from hepatitis. And of course, we know that this is sepsis, severe sepsis, probably septic shock, and possibly endocarditis. So he goes to the ICU. And even though we sent him there, there is a 30 to 40% mortality rate. The young man here, he suffers from Gilberts syndrome, which is completely benign. He can go home, and his prognosis is quite excellent. But in real life, most medical cases at the emergency department in Denmark is something like this, where you have older patients. They really suffer from the same disease that causes them not to know anything about their history whatsoever that you can use for anything. I mean, he claims he doesn't smoke, which he obviously does. He was allegedly bitten by a sheep. And of course, you still make a clinical assessment and try to judge which of these two are sick and which is well. But when it's 3 a.m. in the morning and everyone, his wife has gone home, his wife knew his whole history and she's gone home, so you don't know anything, and it's 3 a.m. in the morning and you get a bit scared and you don't know what to do, so instead you might wind up just admitting both of them. And as Jesper said, a careful estimate of those numbers in Denmark are that we admit probably 20% too many patients on that account. This is of course where suPAR comes in. Given the talks yesterday, I'm pretty happy I included this point because I definitely think that we somehow skipped a bit of the basic research into the stupid questions of science, which is why is suPAR even prognostic? That is sort of strange. But still, in the study that we did, we wanted to go into the prognostic part once again, where we said, well, yes, we have something with mortality, but what does that really mean? It means there must be something with disease severity in a broader sense. And we also wanted to show that this holds true for a cohort of pretty unselected medical patients like the two older gentlemen you saw just before. So we included 540 patients. They had suPAR measured at baseline. And in order to get closer to this point, disease severity, we also registered the comorbidities using ICD-10 diagnosis. We followed them up for 3 months, and we had some endpoints, really a very simple setup in a certain respect. Before I show you the results, I'd like to talk a bit about comorbidities, because as we saw with the first 2 patients, in many cases you can tell from a diagnosis whether a patient is critically ill or not. But if you just go into Danish registries, which are very extensive, you can find in our cohort, for example, you can find perhaps like 5 to 7 diagnoses on every patient. So we had to have some sort of model in order to say, are these diagnoses, are they irrelevant or are they important, or what are they? So we thought that using the Charlton Comorbidity Index could be very nice, because it's quite simply a model derived from logistic regression, where Charlton and co-workers, they took these different diagnoses and they just modeled 10-year survival according to this. And then they came up with, for example, that pneumonia is 0 points, hypertension is 0 points, liver disease is 3 points, and metastatic solid tumor is 6 points, and then you can just add it all together and give some points for age. And then, as you can see, even in the validation cohort, not very big cohort actually, but it's eerily close to the actual 10-year survival, what she predicted from this model. Okay, so basically we just took all our patients and put them into certain groups, and you see the mean suPAR, and you see a Kruskal-Wallis test for trend. Not surprisingly, a connection with age. Also not surprising, there was a highly significant difference between those who died and those who lived, where you see that 48 out of 543 they died within 90 days, so about 10%, and they had quite a higher suPAR than those that lived. But what we really thought was interesting is that admission 0 days, that's less than 24 hours. They had the lowest suPAR of all the groups, whereas just you stay for 1 to 2 days, then it rises. 2 to 7 days, it rises even more. And if you're at hospital for 8 days or more, it rises beyond 7, which is quite a high value in this population. But really the most interesting...
Does it rise, or is that the baseline?
Oh, it's the baseline. It doesn't move anywhere. It's just a higher baseline value. So, yeah. But really what I thought was extremely interesting is the association with the Charlton score, where you can see that actually most of these acutely admitted patients, they score absolutely nothing, which just states that this score is not about how many diagnoses you have, it's about how serious they are. But what you see is that suPAR is higher, the higher Charlton score you end up with having based on the diagnosis upon dismission from the hospital. And even though you can't prove causality in any way from this, usually we'd say that when you see something that looks like a dose-response relationship, then there is a pretty good probability that the association is actually true and not random. Anyway, there was a vigilant reviewer on critical care, it may be one of you, who said that we had to do this figure, which is perhaps not so nice. It just shows that if you have old John and old Stephen here and here, then it's really, even though the connection is there, it's higher when you die after 3 months, then it's impossible really to discriminate based on just one suPAR value. But still, we did some adjusted analysis. These are Cox proportional hazards with the hazard ratio for the listed outcome and then a confidence interval. And if we just look at mortality, we see that when adjusted for age and sex, which are the most obvious things to adjust for, you still have 1.15 hazard ratio estimate for the effect of suPAR on mortality. Not much happens when you adjust for C-reactive protein, that's expected. But actually, if suPAR, for example, was only a marker of comorbidity, then we'd expect the effect to go away when we adjust for a weighted comorbidity score as the Charlton score. But it really doesn't, so it still holds some information that is useful. And given the scale of suPAR, it's actually quite a lot that you increase your mortality risk by 11% for every 1 nanogram per milliliter increase. Anyway, so if we go back to our cases, and we put on some suPAR values. Then, now it's easy enough. I mean, this is a red number, this is a green number, so he's sick and he's well, so he goes home to his sheep and he goes to hospital. But perhaps it's not that easy again. I mean, this I can explain to my grandmother, and we know that this is good and this is bad. But at 3 a.m. in the morning, it's kind of hard to base clinical decisions on some loose figures without some actual risks. So that brings me on to the perspectives, which this coming year we will hopefully have a lot of suPAR samples to analyze. 22,000 samples a year, and we will have a very big material for making models, because the problem with models are, for example, we looked into liver disease in the last cohort here as well, but there were only 8 liver patients. So the problem is really subgroup size, where if you have 22,000 patients, then most of the subgroups can be of quite nice size. And at least what I imagine is that this is the same patient as before the smoking man. Is that of course you have just suPAR listed on the blood test sheet, but when we have a model that works, then it should also say that based on the sex, age, suPAR, and possibly whatever else we might think of, then it actually states what the mortality risk within a certain time frame is, and perhaps a confidence interval. And the next question is, of course, that if you're 72-year-old and you smoke and you suffer from Alzheimer's disease, then what is your sort of background population 3-month mortality? So it can be pretty hard to interpret these numbers and act on them, but I still think that we're not completely done with the prognostic part of suPAR yet, because we still need a model that works and that puts out some actual numbers we can use and go on with. Another point I'd like to make is that, as we saw with the Charlton score, when I hear predicting, I think that it means, for most people, is that you can say something about a single patient, that he dies or he lives, or it goes well or it goes badly. But what this really means is, of course, that you can put 100 patients with these exact data into one group, and then if you're right, between 13 and 17 of them will die within 3 months. But even if you had all the data in the world on these 100 patients, you probably wouldn't be able to determine which 15 were the ones to have a bad outcome. And I think that's an important thing to note about risk stratification, is that it's a risk, it's not a crystal ball. Lastly, I'd just like to say that actually triage, it started in the Napoleonic Wars, where of course it was important to see that, oh, he is quite well, we don't need to treat him. Not so well, we need to treat him. But you also had to say that, oh, he's fucked, we don't treat him at all, just leave him behind. And even though we lack funds in many healthcare providers, at least it's a bit different today. So thank you very much.